So our mean arterial pressure should be 65 or greater. If it is below 65, then we are not getting the proper perfusion that we need, okay, to maintain the organs. So 65 or greater. The mean arterial pressure is the cardiac output times the peripheral resistance. So somebody tell me what cardiac output is. Stroke volume times heart rate. What's stroke volume? The amount that left ventricle pumps each time, right? What is peripheral resistance? What's that mean? It's the pressure it takes to pump that blood out, and it's dependent upon the size of your arteries or your arterioles, okay? Pulse pressure, that is your systolic minus your diastolic. Normal is 30 to 40. So if we start having, you've heard narrowing pulse pressure or widening pulse pressure. If it starts narrowing, this means that we are not perfusing like we should. If we get below 30 or 40, we're not perfusing like we should. What you're gonna see first, if you start seeing a narrowing pulse pressure before a drop in that blood pressure, that's usually an earlier indicator. But whichever one that you notice first, remember, damage has already occurred where? At that cellular level. So our cardiac output is already decreased. Widening is meaning we have more vasodilation. That's another discussion. Don't get that confused. We're concerned with narrowing today. Okay. The 3 stages, okay? Let me add that your book talks about an initial compensatory stage. This just means that the patient is beginning to go into shock, but you're not seeing any changes yet, okay? But your book does talk about it, but y'all don't get too involved in that. Don't get bogged down in that. Okay, so the compensatory system. What does your sympathetic nervous system do? What's it do? Flight or fight, right? Increases everything, speeds everything up. What's your parasympathetic system do? Slows down, it's kind of laid back, chilled out, right? So this is an increase in the sympathetic nervous system. So that's why we have the increased heart rate, increased blood pressure, increased contractility, increased cardiac output in the compensatory stage, okay? Now, because of the vasoconstriction, most of the time your blood pressure is going to be normal. Most of the time. It's probably not going to be like, and y'all listen to me. What is normal blood pressure? 120/80. Am I ever going to give that to y'all? No. If I gave y'all a 116/72, is that still normal? Yes. If that's all you have is that blood pressure. If I gave you a 132/84 and that was it, no other symptoms, is that still okay? Yes. Okay? Now, if you get into 160s, 180s, that's hypertension. Okay? Low blood pressure, you're going to know it's a low blood pressure. Okay? But a normal blood pressure, just remember, Ms. Hosey is never going to give you 120/80. That's just too much. Okay? But with compensatory, if you see a normal blood pressure, a high heart rate, decreased urine output, cool, clammy skin, hypoactive bowel sounds, that's compensatory. Look for your blood pressure. Look for your blood pressure, okay? All right, so if we're shunning blood away from the skin, is it gonna be warm or cool? It's cool. We don't have any blood out there. It's gonna probably be clammy. If we don't have bowel sounds, if we don't have perfusion to our bowels, what do we see? Hypoactivity. This goes back to burns. Y'all remember that? Decreased peristalsis, decreased bowel sounds, risk for paralytic ilitis. All that's coming back to you with the burn. It's all coming back. just gonna stick to it. Okay, decreased perfusion to your lungs, what do you see? What would you see? If I'm not getting any blood flow, any perfusion to my lungs, what are they gonna do? Are they just gonna work pretty like they normally do? What are you gonna see? Drop in O2. That y'all think normal, just think basic. Drop in O2. What's my SATs gonna do? Decrease. What's my respiratory rate gonna do? Increase. What about my capillary refill? It's gonna increase, right? What about edema? Am I gonna get some pulmonary edema going on? Who had a patient, they saw, was it one of y'all? They saw flash pulmonary edema in one of their out rotations. Was it one of y'all? It may have been my other group. Somebody was telling me they actually went to the ER and a patient coughed in a cup and they're like, I looked in it and it was literally pink, frothy sputum. And they had never seen that, like visually, seen it in real life. Okay, what about your renal system? We know decreased urinary output, what else? Tries to compensate for your blood pressure. You got a lot of things going on, right, to keep that blood pressure normal. Can you have pain? Can you have dysuria, burning when you pee? What's your urine gonna look like? Dark, maybe cloudy, it's gonna be real thick. Urine specific gravities are gonna go up because it's so concentrated. You have kidney pain or you have leg pain. Okay, this is another chart. I just put it together for y'all because to me it tells you everything you should see right there in one chart. My respiratory rate, 22 breaths or greater, okay? I'm going to stick to these charts because that is your resource, okay? So again, I'm gonna stick to these charts. Look at your mentation. Why do you have confusion or agitation? Decreased cerebral blood flow, right? In this stage, they're just going to be anxious, confused, or agitated, not lethargy, not comas yet. We're not there, okay? But they are gonna have some mental abnormalities. Yes? Decrease. When you push it, because they have decreased blood flow. Yeah, more than 3 seconds. More than 3 seconds. Sorry, I went too far. Okay, so what do we need to do? If we have decreased perfusion, what do they need? Fluids. Is oxygen going to help? Okay. Y'all listen to me. I'm trying not to confuse you. ABCs, we're gonna stick to that. ABCs, okay? So it's always airway and breathing first. However, in shock, so listen to me. ABCs, just remember that, ABCs. But if you slap a non-rebreather on them and do nothing else, you are not going to help them because they don't have the circulation. So technically, circulation is first in shock. But all of your resources reference ABCs, so I'm sticking to ABCs, okay? But in real life, the fluids are more important than actually the oxygen, unless you need to intubate them. If you need to intubate them, of course, that's always first, okay? But ABCs. So circulation is huge in shock patients. What kind of oxygen do you think these patients will need? Where do we start? What do they need? High flow? What do y'all think? We're in the compensatory stage. My body's trying to correct itself. Do y'all think we could start with a nasal cannula? See where we go? And titrate it to maintain our sats? Probably. It would depend on what I gave you as the patient. If my sats are 84, are we gonna start with a nasal cannula? No. You could probably go to a simple face mask, non-rebreather. But if my sats are like 92, could you start with nasal cannula? Absolutely. So just look at your patient. That's your patient. What would you do in that hospital room? What would you put them on? Okay? Now, I have up here monitor and restore tissue perfusion. So what do I mean by that? Give me some examples. Fluid boluses. Vasodilators, medications. We're gonna get to those in a minute, but absolutely. Assess your patient very often. So vital signs, very often assessment of your patient and their oxygenation perfusion status. What if they're in pain? Does that increase your oxygenation perfusion use? Absolutely. Treat pain. What does fever do? Does it increase your myocardial demand? So treat your fever, treat your pain. You may have to sedate them, depending on how bad they are. What about, do they need to be up doing activities? Do they need to be up walking? No. If you have to give a bath, what do? Keep them in their bed. They don't get up to showers. Cluster activities, okay? Anything that decreases that myocardial demand. What if we give them some fluids, we give them some vasodilators, nothing's helping that blood pressure? How can we increase the oxygen carrying capacity? What can we give them? Not yet. What do you do if your H&H is low? Blood or blood products. You can give them blood products. Okay. This is what you notify the healthcare provider for. Our systolic blood pressure has now gone below 100, or there is a drop of 40 millimeters or more in your blood pressure. So they come in and it was 100 systolically and now it's 60. Or it was 150 and now it's 110 or 100. So 40 or more, you need to report that. Of course, if your MAP is below 65, you need to report that. And then concurrent diagnosis of infection. If they have pneumonia, they have a urinary tract infection, any kind of infection, and then they develop 2 or more of these, you need to report that. Well, guess what? These are all symptoms of what? Your next stage, progressive, okay? So you're gonna move to the progressive when the compensatory mechanisms have failed. Now, instead of maintaining our blood pressure, we have a dip in our blood pressure. We can't maintain it. We're gonna have hypotension, okay? This is when our pump, our heart, is not able to contract normally. So we're not able to maintain our cardiac output, our ejection fraction, or our blood pressure. Now, do you see where I have intense inflammatory responses? I told y'all with every shock, that inflammation process is expedient or in overdrive. Now we're really in overdrive. So this is where we start getting into more of a risk for that bleeding and clotting, that DIC. We start getting into a higher risk of that, okay, in the progressive. If our heart is not pumping the way it should, what are we at a huge risk for that y'all just had a test on? I heard it. Dysrhythmias. If that heart's not pumping. Also, what else? Dysrhythmias and what else? Be right or left-sided? Heart failure. Okay, you start getting into all those heart and lung problems. Okay, I told y'all with compensatory, our respirations were rapid but deep, right? Now they're going to be rapid and shallow. So, If I'm breathing very fast and I'm breathing deep, I'm blowing off that CO2, right? That's why we have respiratory alkalosis. If I'm breathing fast but very shallow, am I having effective respirations? No, so I'm holding on to my CO2. Okay, I'm holding on to it. Even though I'm kind of hyperventilating, I'm holding on to it because I'm not blowing off. I don't have effective ventilations. We talked about our pulmonary vasculature. We said we were at risk for pulmonary edema, right? It's just an even greater risk, y'all. You're gonna start having what they call some physiologic dead space, and it's just like where the lungs are, you're trying to breathe the air in, but you're not breathing it in good, and it's not perfusing all the areas of the lung that it needs to. It's called a VQ mismatch, or VQ perfusion. Look at the bottom. What are more symptoms you're gonna start seeing that you didn't see with compensatory? Crackles. Now we're in crackles. Even more dyspnea, more work of breathing. Have y'all had ARDS? I think y'all did first test. ARDS, this is where ARDS comes in, that acute respiratory distress. This is where it comes in the progressive stage. You can also have what's called ALI, which is acute lung injury, and it is when it's kind of like pulmonary edema, when the lungs are just bombarded with large amounts of fluid at one time. It can be called pulmonary edema or acute lung injuries, ALI. Y'all good? I'll move along. Okay, we've already talked about the dysrhythmias. I skipped that. Now look at your heart rate. You had tachycardia, right, with compensatory, but now your heart rate is going to be 150 or higher in progressive, 150 or higher. You're going to start having chest pain. What's another word for chest pain that I may use? Angina, either one. Look at your cardiac enzymes, your troponin and your CKMB. All of those are going to increase. Now let's look at our pulses. Weak peripheral pulses, decreased capillary refill. What is anasarca? It's profuse edema. In burns, we talked about all that fluid going out into the interstitial spaces, and it was just kind of out in our periphery, right? Well, this fluid is out in our periphery, but it's going to actually start affecting those solid organs now. So it's going to affect the liver and the pancreas and all of those organs, okay? So it's just even more profound edema. Huge amounts of weight gain in a very quick time. Okay, neurological. We had what in compensatory? Agitation, maybe some confusion, right? Now we can have that. We can have mild symptoms that progress up to lethargy and maybe even altered level of consciousness. They may actually go into comas here. All right, our GI system. Y'all already know what they have, right? Decreased bowel sounds, distension. Now, say it again. Paralytic ileosis. If they have the ileosis, what are they going to have? What will you see? Distension, tenderness, decreased up to absent bowel sounds. Okay. With burns, I told y'all they needed to start tube feedings within about 4 hours, right, to promote that peristalsis. With shock, they need the same. We're going to talk a little bit more in detail, but they need those feedings, but they're going to be at much decreased amounts, and we're going to start them a little bit later. Now let me say this. If we have bowel sounds, we're going to feed them through a PEG tube or NG tube, right? But what if bowel sounds are absent? Do you feed a person whose bowel sounds are absent? Why don't you feed them? Where's the food going? It ain't going anywhere, it's kind of sitting there, right, because the stomach can't move it, and we're just going to have a hot mess, and we're gonna have all of this sweet fluid, feeding, sitting there, and we're gonna increase our risk for what? Aspiration, and also bacteria from infection, okay? We'll get to food a little bit, okay? Okay, I told y'all in shock we were gonna talk about compartment syndrome a little bit more abdominally, right? Okay, with the abdomen of compartment syndrome, if your stomach has a lot of pressure on it and it's full of fluid, where is our diaphragm going? It's going up. So what does that do? Decreases your lung expansion, makes work of breathing harder. What's it do to your cardiac system? Presses on the heart, which means it can't contract the way it should. Okay, so we have decreased cardiac output. What does it do with all this blood coming from the peripheral system trying to get back to the heart? Kind of blocks it, so it increases that peripheral resistance, right? So it decreases the preload. So it has a lot of cardiac respiratory manifestations, okay? So how do we fix compartment syndrome in the abdomen? Surgery, paracentesis and or surgery, okay? They've got to have a procedure to fix that. All right? We talked about renal. I'm not going back over that. Remember with renal, you will see increased BUN and creatinine because we have decreased urinary output. What about our GFR? What does GFR stand for? Glomerular, I cannot say that word, filtration rate. It's going to go up or down? It's going to decrease. What is normal in an adult? I think I heard some of y'all talking to Miss Miss White about that. Some books are going to say 90, some are going to say 60. For me, for shock, I'm used to 60. If the GFR is off, it's going to be off. You will know it, okay? You're looking for a low GFR. You're looking for a low. That's abnormal. All right, with our liver, our immune system protects us from what? Your immune system. From what? Everything from infection, right? So if our liver, we have a loss of immune function because our liver cannot function the way it should. So we have increased risk for infection. We have increasing bilirubin levels, which means what? With those babies, y'all already learned that. Jaundice. We're going to start seeing jaundice. If you don't see jaundice in the skin, where else can you look? The eyes, okay? Where do you look in the eyes? Well, there's those eyelids down, okay? AST, ALT, and LDH, what are those? Y'all learned about those? I know you have. You need to know your normals. You need to know your normals, okay? Okay. Progressive, it didn't work. Our body did not correct itself. All the interventions we threw at the patient didn't help. So then we go into irreversible. Irreversible is very simple, y'all. Everything gets worse. The patient is not able to maintain homeostatic stability without medicine, without fluids, without mechanical ventilation, without a CABG or a ventricular assist device. They've got to have some kind of either medication or they've got to have some kind of, what am I looking for? Equipment to help them maintain their homeostatic stability. So they're irreversible. So everything gets worse. So what do you think your nursing function is? What is your nursing priorities now? Comfort care, keep them comfort. We're still working on them. We've still got them on a vent. We're still giving them all the vasoactive medications. They're still getting fluids. But we start to shift to where? more of comfort care. So who do you need to be talking to? Family. And you kind of have to start taking care of that family too, okay? Y'all do not let those families walk in and see that patient now on a vent and nobody's warned them. Or they've got, their blood pressure has been, you know, in the 100s systolically and now it's in the 50s and nobody kept them up to date. So your shift, you're still focusing on your patient, you're still taking care of your patient, but you also have to shift some of your focus to that family. Okay? Do we need a prize? Do y'all need a break? We need a prize real quick. This is a lot, I know. I lost my wheel.
I wonder if they're doing this little
Hush.
class because we could like not have any good private classes. There's so many names on there.
Caleb?
Woo! Woo woo!
And Emily.
I'm scared for the time they're gonna ask a question.
Okay, do y'all need a quick bathroom break? Okay, let's come back at 9. Okay, so this chart that I gave y'all, it just differentiates the two, so you can tell one from the other. Look at your blood pressure, what's different? Right, one is gonna be still getting fluids and or vasoactive medication. The other one is not going to be able to even maintain a blood pressure without probably an LVAD, an open heart, a balloon pump, something going on to help, okay? Your heart rate. Your reversible says erratic, right? So it can be all over the place. Respiratory status, remember they've got to have a mechanical ventilation. Look at your skin. It's now jaundiced and irreversible. Urinary output, it's going to be low in everything, right? Except for irreversible. And uric means what? 0. We have 0 output, or virtually 0. So they're going to have dialysis. With augmentation, with irreversible, they're in a coma. They're unconscious. Okay? So you've got to know the differences, be able to differentiate the two. I had a discussion with a student. Y'all be careful, like when you're studying, you get used to the word bradycardia, right? They're gonna be bradycardic, they're gonna be bradycardic. I could give you the word or I could give you a number. And I think some of y'all are missing questions because you're so tuned into that word, you're looking for the word that you're missing the number. You know hyperglycemia, but when I throw you a high blood sugar, it's just not clicking. So just get used to, we can give you the number or we can give you the word. And I promise you I'm gonna do that, okay? So just get used to that, okay? All right, this is just some pictures I wanted to show y'all. Cold and mottled. That picture, the bigger picture on the right, that's that mottled. It just kind of looks kind of, I don't know, speckled to me is my word, but that's what mottled looks like. And then these other two pictures are called petechiae. It's where the little blood vessels come up under the skin and kind of pop. That's petechiae. Petechiae can be really scattered and diffuse, or it can be more in one area like it is kind of on that leg and foot, okay? We're going to talk about petechiae a little bit more with DIC, but just to kind of show y'all some pictures. Okay, so the way I did this, for every type of shock, we're going to have some general stuff we have to do. And then when we get into each individual one, you're going to have a little bit, some things are going to vary, okay? But go by this general, I have to do this for everything, unless there is an exception like with cardiogenic, there's some exceptions, okay? So of course, early identification, we need to identify our patients at risk. When we get to hypovolemic, we need to know who's at risk. okay? Cardiogenic, who's at risk. The more effective we are in identifying and treating the underlying causes, the more effective we can be at treating shock and keeping them from getting to the irreversible stage of shock, okay? So your book is very, very big on prevention and early identification, okay? All right, so for every type of shock, those boxes that I gave you that told you the vital signs, what the skin looks like, what the urine looks like, it's all right there in the first box. You're assessing every bit of that. How often are you assessing it? What do y'all think? It really depends on your patient, right? Normally we do assessments like every 4 hours, kinda. But if you think your patient is going into shock, you're probably gonna go to like every hour or maybe every 15 minutes. You're gonna do it very, very frequently, okay? You need a brief history. What led up to the shock? Did they start a new medication? Did they travel somewhere? Did they get a new vaccine? Did anything new? If they were involved in a trauma, if they had a baby recently, if they've had a recent stroke, just anything in their history you need to know. And then when did it happen? Okay, the onset. Why do y'all think I have this up here? Allergies, medication, vaccinations. Why do I have that? What do you think these are trying to get to? Anaphylaxis, okay? Just kind of doing an assessment of them. Okay, so for oxygenation and ventilation, we've already talked about this really, right? They need supplemental oxygen, whether that's the nasal cannula all the way up to intubation. It depends on their hemodynamic status. But we need oxygen on them and we need fluids on them, right? Okay. Cluster activities that increase O2 consumption, that's huge. Don't go in there and do passive range of motion and then turn around and do a bath and then turn around and do something else. You need to kind of cluster it, but you need to do like a big bath with something little, then let them rest, okay? They've got to have plenty of rest. For your mixed venous oxygen saturation, y'all don't have to know a whole lot about this. They monitor this in the ICUs. What they're measuring is what is the oxygen capacity of the blood that has perfused the peripheral system, how much is still in the blood when it comes back to the right atrium. They can measure that and see how much consumption the body's using, okay? That's just another way that they measure how much is, I'm sorry, somebody asked something? Okay. Okay, so fluid replacement. I told y'all it's the cornerstone, right? It's really the number one, but we're gonna call it the number two for testing purposes. Look at the ones I listed: septic, hypovolemic, and anaphylactic. What am I missing? Cardiogenic and neurogenic. They do not get fluid boluses. We've got to be a little bit more conservative with them. Okay, they're a little bit different. But septic, hypovolemic, and anaphylactic, we're gonna pour the fluids on them as fast as we can. They're gonna get boluses. What do you need to be monitoring if you're giving boluses? Fluid overload. What do you see in fluid overload? Crackles, edema, increased work of breathing. If you do not know, you need to look over that, okay? 1 or 2 large bore IV catheters, we prefer a central line, right? We prefer a central line, some kind of PICC line, central line, midline, one of those central venous catheters. But if you can't have that or you don't have access to that, 2 large bores. What's intraosseous? In that bone. Has anybody ever put one in? I had to one time and it grossed me out. I put one in the leg and it grossed me out and I did not want to use it because I didn't trust myself. But I was in an ER where we just could not get anything and actually a paramedic helped me and I was just like, ugh. Anyway, we can use them if we have to, right? Okay, our fluids. Isotonic crystalloids, the normal saline and the LR. What's your first choice? What do y'all think is first choice? LR. It has lactate ion in it, which is converted to bicarb, which treats the metabolic acidosis. What do you think people use more? Normal saline. What's the problem with normal saline? Doesn't correct the acidosis or the electrolyte imbalance. If you give too much, what's gonna happen when that vascular system gets full with normal saline? Edema is gonna go out into those interstitial fluid, tissues, which are already edematous. So you're gonna have even more. LR is gonna stay in that intravascular system, okay? So LR is our first choice, but again, either or, okay? Colloids, the albumin, when do we go to those? When our crystalloids are not working, we go to those colloids. They kind of bring all that fluid back from the interstitial tissue back into the intravascular, okay? We've already talked about blood products. We may have to give those to replace blood they've lost or to help with that oxygen carrying capacity. Why do I have fluids are given warm? Large amounts of fluid given very fast and very cold can cause what? Hypothermia, and what else? Cardiac dysrhythmias. They can actually cause dysrhythmias. So you want to give them warm. Okay, on one of my Kahoot questions, I had 3% normal saline. That's a hypertonic crystalloid. Have y'all ever seen that given? You haven't? I've been a nurse for 20 years. I've never seen it given, but it is available. But you do not give it in shock. It doesn't draw the fluid in and increase that vascular space, okay? But your book talks about it, but all I want you to know is that's not your choice, okay? That's not your choice. Okay, vasoactive medications. These are your norepinephrine, your epinephrine, your dopamine, your Dopitrex, all those medications. We give these when our hemodynamic status is not supported and maintained by fluids or colloids. We're going to start going to the vasoactive medications. Now we're going to vital sign monitoring every 15 minutes, okay? These patients should be in the ICU. However, in today's world, especially when COVID was going on, I actually saw some of these patients on the med-surg floors, okay? They tried to do that short term until an ICU bed came available, but sometimes that didn't happen, and these patients were on the floor. So every 15 minutes or more. Now you see I have on here, they're administered through a central line and on a pump. These are not set to gravity. Does anybody know what I mean by a dial-a-flow? It's a little, I don't know, it's a little round thing, and you can actually put it on 75 or 100 or whatever, and it is supposed to regulate just like a pump. These are not used for these medications. They have to be on a pump. If you are in a situation like a code and they have a peripheral IV and it is life-saving, they will use a peripheral IV. That is not recommended, okay? But they will use them. If they use a peripheral IV, this extravasation, this eating of tissue is what can occur if those fluids come out into that tissue, okay? So that's why we don't want to use them. We had a patient on 2 North who took care of that little fella when he was like really bad. Who took care of him? My people. Who went to surgery with him? Okay, Emory, Lindley, so this guy came in with an infection, he got septic, he went to the ICU, and long story short, he was put on Levophed, norepinephrine drip. And he got this, not due to the extravasation, but due to the constriction and the tissue hypoperfusion. Tell him about it. He had this where?
On his toes, on his feet, both of his hands. He got both of his feet amputated.
He's now got a left
His stomach.
above the knee. His hands, y'all excuse me, but on his left hand, he has this one finger. This is what he looks like. One finger. This hand, he has none. He has no foot on the right, and he lost half of his leg on the left. Yeah, both feet, yeah. So all of that just from norepinephrine. And that was for a central line, okay? So just remember, we don't want them in a peripheral because you can have this type of injury from tissue perfusion, or if it's given through a central line, you can have it from tissue constriction and no blood flow, okay? Dosages are titrated. You're going to have a chart that says if your blood pressure is this, titrate it to this, you're gonna have a protocol. Why do I have never stop abruptly? Why do y'all think? What can happen to the patient if you say, oh, that blood pressure's good, let me just click that pump off? You're gonna probably kill them, right? They're gonna have a rebound effect, and we're probably gonna kill them. So you have to titrate it off and titrate it slowly. Okay, titrate it slowly. I'm off my high horse. That happened. Okay, this is your chart. This is a list of the medications. What I want you to know is with the medications, which ones am I gonna give? Which ones, what do they do? Okay, which ones do I give and what do I do? What did they do? So it used to be, we always started with hypotension. We always started with dopamine and we went to Levophed. That was common. Now a lot of places are kind of skipping dopamine and going straight to Levophed. So I'm not gonna trick you with that. Norepinephrine is huge in use right now, so that's kind of the one that I'll probably stick to the most. But epinephrine is used a lot. And then don't forget about like your nitroglycerins and all for your vasodilation, for chest pain and all. Okay, back to our nutrition. Let's talk a little bit more about that. With these, they're often called trophic, T-R-O-P-H-I-C. When you're in shock, they'll say trophic feedings of how many ever milliliters an hour. They're usually gonna start at 10. They're gonna start very low and go slow with feedings because we've got this decreased hypoperfusion. So they do need the feedings. They're gonna try to start them within about 24 hours, give or take, but usually about 24 hours. And they're going to start them low and then adjust them as the patient tolerates it. How do you know if a patient is tolerating tube feedings? Vowel sounds, residuals. Residuals are huge. Okay, vowel sounds, residuals, distension, okay? 3,000 calories a day. Their energy expenditure is about 1.5 to 2 times their normal. So your book goes with 3,000, so that's what I will go with. Don't get it confused with burns. But with shock, we're gonna go 3,000. You've still got your PPIs, you've still got your H2 blockers. You're gonna keep all of that just like you did in burns. Which one do you want to go with first, enteral or parenteral? Enteral. Parenteral is if they cannot tolerate enteral feedings. Or if you had no vowel sounds, they will go to parenteral because we don't want to put anything in that gut if we don't have vowel sounds. For daily weights, what do you do if you check a weight and they have lost weight? Do you increase their feeding, or what do you think? It's probably more related to dehydration and fluid loss. So look at your dehydration status before you just start increasing tube feedings. We don't wanna put a lot of tube feedings on them. Okay, for your glycemic control, there's a lot of information out there about this. So what I could find the most up-to-date, evidence-based, was your sugar needs to be less than 180. It used to be that they wanted you to keep it 60 to 100 or 60 to 110, which was quote normal. Now they're saying it's okay for those sugars to be a little bit higher. So I'm gonna go with less than, it just needs to be less than 180, okay? That's the most recent I could find. What does all those labs up there tell me? What is albumin, pre-albumin, what do those tell me? Protein, nutritional status, so they'll be getting those. Of course, they're getting electrolytes and all that. Okay, now we're gonna switch to the 5 different types of shock, okay? So for our low blood flows, hypovolemic and cardiogenic, your book calls the distributive shock, which is what I call them, but you might also see circulation or circulatory and maldistribution. You're gonna hear me say distributive, okay? But if you see any of the other words, it's the same thing. So tell me overall, in hypovolemic, what do we have? Volume loss, 15 to 30% or greater, okay? With cardiogenic, what's the main thing? In general, what's the main thing with cardiogenic? What? Yes, but what's happening? Why do I have cardiogenic shock? What's not working? My heart's not working, right? That pump's not working. With neurogenic, what's going on? It's basically some kind of spine trauma. It's something to do with spinal anesthesia, some brain injuries, we're not gonna get specific about them, but you have a loss of sympathetic and parasympathetic control. They kind of go against each other. What about anaphylactic? Was allergic reaction to something. Septic, main thing with it, what is it? Infection, okay? Just kind of a generalized overview. Okay, so for hypovolemic, it's our most common period. Most common, I told y'all 15 to 30% or greater blood loss. So give me some examples of why you would go into hypovolemic shock. Gunshot wound. Motor vehicle accident. Lacerated your liver. What else? Shock. Hypovolemic. Why do you lose blood? What about OD? Postpartum hemorrhage. Woo, big one, big one, big one. Y'all have postpartum yet? Y'all done that? Y'all have a test on it? Guarantee you'll have a test on postpartum bleeding. It's always on there. I don't know, I don't see that test, but it's always on there. That's the #1 complication. What else can you have? Ooh, my abdomen is so hard. So dry. Just like a brick. I'm pregnant. It's so hard. Oh, Lord. Eruption. What about my placenta not working right? Insufficiency, placenta previous. Placenta's not where it should be. What about cancers? Think you can bleed from chronic cancer? Absolutely. Okay. What about if I am a diabetic? Can I have hypovolemic shock? From bleeding? From diuresing, DKA, HHS? Okay. What about if I have liver failure? Where can all that fluid go? Some will start swelling, gets real big, and I have all that stuff going on. Ascites, okay? What about nausea, vomiting? Diarrhea. You're either losing blood or you're losing fluids, okay? So anything that causes you to lose blood or fluids is a risk for hypovolemic shock. Y'all missed one of the big ones. My other leg. Okay. So, here's your clinical manifestations. Weakness, dizziness, anxiety. Tachypnea, tachycardia, right? Body's compensating. Blood pressure and stroke volume, of course, is gonna be decreased because I don't have enough blood in my intravascular system. And my urinary output is decreased. Okay? Hypovolemic, you just need to know the signs and symptoms. When we go to the next one, we're gonna look at what's different. Okay? So how do we treat it? Treat the underlying cause. What if I'm a diabetic and I'm in DKA? What do? What do you give me? Insulin, fluids, probably some potassium. You gotta treat that cause. If I'm having nausea and vomiting, antiemetics, some fluids. Okay? What if I'm a postpartum bleed? Fundal massage. Okay? What if I retain fragments? Placental fragments? DNC. You got it. What if I'm in a car wreck and I come in and I have a femoral artery fracture and it is spewing blood over there on the wall? Pressure. Okay? Stop the bleed. Stop the source of your hypovolemia, whatever that is. Whether it's holding pressure, whether it's going to surgery, whether it's giving me a medication. Okay? You gotta stop the source or the cause of my hypovolemia. We've talked about fluids. With hypovolemic shock, again, LR is going to be my choice. Always my choice. First choice. But normal saline is also another choice. Look at your fluid resuscitation, the 3-to-1 ratio. Most resources are going to go by this. You get 3 milliliters of fluid for every 1 milliliter that you lost. So if I said they had a 600 milliliter loss of fluid, what is your fluid replacement? Oh, that's a good test question. I didn't put that on there, but what would be your fluid resuscitation? 1,800 milliliters. Okay? It's a 3-to-1. So if I have 1,000 milliliters of fluid loss, I tell you that. Postpartum hemorrhage, patient had 1,000 milliliters of blood loss. What is your fluid resuscitation? 3,000. You just triple it. 3-to-1. Does anybody not understand that? Blood would be different. We're gonna go with just fluids. Blood will be different. Okay, do these people need oxygen? Absolutely. Again, from nasal cannula all the way up to intubation, depending on their status. Okay, I gave y'all the treatments I want you to know there for hypovolemia. We're either gonna give epinephrine or norepinephrine. Okay, I'm gonna try to make it simple for y'all. Okay? Okay. Modified Trendelenburg. Why do I want them in this position and not this position? That's Trendelenburg. Venous return, right? So right here, where is my venous return coming to? The heart, to my core, right? Your book also talks about passive leg raises, if y'all saw that. This is how you would put them for passive leg raises. You would do this, see if my blood pressure improves. If it improves with this, then fluids are gonna help and maintain my blood pressure. If I do this, and it does not maintain my blood pressure, then fluids are not gonna help me, okay? But this is the position you want them in for hypovolemic shock. We want that venous return to come back, but we don't wanna overload them. If we do this, everything is coming up and we're gonna flood not only my heart, but my lungs, because we have so much fluid coming at one time, on top of all the fluid that we're giving them through their IV. We're gonna suffocate them here. This is actually going to increase our work of breathing. Questions? Y'all good? Okay. Cardiogenic. Y'all told me the heart's not pumping right for whatever reason, whether it's a heart attack, it's blunt trauma, it's a pericardial tamponade, whatever's going on with that heart, it is not working right. Okay? So we are not getting oxygen and blood out to where it needs to be. So, look at what's different. Did you have tachycardia on the other one? On hypovolemic? They were tachycardic and tachypnic, right? Was our blood pressure low? Yep. Says dysrhythmia is new? It's new, right? Alright. Angina, is it new? Fatigue? Tachypnia? Nope. Cool, clammy skin? It's kind of new. I will tell you on hypovolemic, they're gonna have cool, clammy skin too. Just depends on how much of a volume they're in, how much of a volume deficit they're in. That's why I didn't put it on the other one, okay? But they will have cool, clammy skin depending on their hypovolemic state. Anxiety, confusion, agitation, decrease urinary output. Okay? So, we need to maintain our SATs greater than 90%, so they need the oxygen. They need pain control, right? Now let me say this. If I'm in an MVA and I've lost a lot of blood from a broken leg and a severed femoral artery, is my leg going to hurt? Yes, even though I'm in hypovolemic shock. You're going to treat my pain, okay? But with hypovolemic shock, it depends on the mechanism of what caused their shock. So if I gave y'all a broke leg or a broke bone or something you would know they would have pain with, then treating pain would apply to them. Does that make sense? DKA, nausea, vomiting, something y'all would know they shouldn't be in pain, okay? But if I give y'all something that says broke leg, broke arm, multiple crush injuries in MVA, you would know they would be in pain, okay? Okay, so for cardiogenic, we said, I've already told y'all, you would not bolus these people. Why do you not bolus these people? They need fluids, right? They need fluids, they're in shock. But why don't we bolus them? Because that heart isn't pumping, so if we load them up with fluids, what are we gonna do? We're gonna smother them and probably kill them, right? Because our heart can't pump it out as fast as we're putting it in. So again, they need fluids, but they're gonna get it just more conservatively. We might be giving them fluids and also giving them diuretics, okay, to try to keep things balanced. Now, I gave y'all some medications over there. I've added dobutamine and nitroglycerin, so you need to know about those. Tell me some common things y'all already know about nitro. Shakes. What's it give you real bad? Headaches. It's a vasodilator. We're already hypotensive. We may have to throw some nitroglycerin on board because they're having chest pain. What's it gonna do to our blood pressure? Gonna further lower it, right? Gonna further cause hypotension. So again, it's a balance, y'all. It's a balance of giving them fluids, diuresing, pulling it off, probably throwing some albumin in there. It's just kind of seeing how they respond. Why do I have angioplasty with stenting? What is that? They go to the cath lab, they have an angioplasty, they go up through there, look at all the blood flow to the vessels, because if this is happening because we had an EMI, now we have a blockage, they just need to open up that flow, right? That's why we're having a perfusion problem. They're usually, whenever they think they're in cardiogenic shock from some kind of blockage, they're gonna take them to the cath lab within an hour. The sooner they can get it open, the better. So they'll take them in there just as soon as they can. Does anybody know what a balloon pump is? Y'all seen those yet? In the ICUs you have? Tell me about it.
They go into the aorta.
Goes in the aorta.
And it balloons up, the balloon goes up with a heartbeat, I believe. It helps your cardiac output.
Helps with cardiac output. It almost functions it has a balloon on it that literally does this. It blows up or inflates and deflates, and it helps that left ventricle with cardiac output. Okay, what about an LVAD, left ventricular assist device? Y'all seen those? Those are pretty cool. When they come in, nobody messes with them except for like I think it's here called the electrophysiology. I don't know, every hospital has them different, but whichever department in that hospital that's responsible for putting them in, when they come in, you send them straight to that department, just straight on if they're having a problem. They have to wear a bracelet, sorry, or a carrier card. What's cool about them? Do you might know?
Feel the pulse.
No pulse.
Or
Do you
blood
shock
pressure.
them?
Nope.
No, they have no pulse. You can feel for pulses everywhere, you can't feel a pulse. But they take the place of the left ventricle. It is the left ventricle. So a lot of these patients, depending on the abilities that they have left of cardiac function, they may get one of these mechanical assist devices, okay? I don't expect y'all to know all about them because those are very specialized, but you do need to know, I would be concerned with like nursing care. If they have something that is taking the place of their left ventricle, or they have something that is basically working as their heart, what are some things y'all need to know? What do y'all think? If you have a patient that's on a balloon pump or has a left ventricular device, so a device, a machine, is now become their left ventricle, what do you need to monitor for?
Infection.
Battery, this machine, that it's working correctly, right? You need to make sure it's doing what it should do. What else do you need to do? Know their baselines. Be monitoring for changes, even slight changes, y'all. Sometimes a slight dip in blood pressure, or a slight dip in heart rate, or an increase in something. So let me ask y'all this. For all of these patients in shock, are we getting manual or the little Dynamaps that roll around? Do y'all think that's appropriate for these type of monitoring? I've got to get it every 15 minutes if they're on a vasoactive medication. What do y'all think? What do we want on them? We want an arterial line, right? So it gives us those continuous blood pressures. What if we don't have that?
Manual.
We need one that we can cycle. We can set that cycle, that blood pressure machine to cycle every 15 minutes or sooner. What do y'all need to know? We're dumping huge amounts of fluids on them. So we need to be monitoring what? Output, so y'all want a what? I want a Foley, right? I don't want them peeing in the bed and I gotta change them 500 times. So you need a Foley. Okay. Okay, neurogenic. An unbalance of sympathetic and parasympathetic. Okay, y'all told me that sympathetic means fight or flight, speed up, and parasympathetic is just kind of laid back and cool, calm, and collected, right? So we have an imbalance with neurogenic. With neurogenic, what I want y'all to know, spinal cord injury, some brain injuries, and spinal anesthesia. So what happens is we have massive vasodilation. So all of our blood is going to kind of pool in the peripheral system. If blood is pooling in your peripheral system, what are you at an increased risk for? DVTs. So we've got to be monitoring for DVT, and in response to that, PEs. Okay? So we've got to be monitoring for all that. Okay, this one's gonna be different. Hypotension, that's been the same, right? But now we're gonna be bradycardic instead of tachycardic. We're going to have warm and dry skin. Those are your differences in your neurogenic. You have up here inability to regulate that body temperature, that's called poikilothermia. It happens with spinal cord injuries, and it's where the body, if you put them in a very hot room, they become hyperthermic, and then vice versa, they can become hypothermic. I wish my body would do that, because I would stay in cool all the time. Just saying. Poikilothermic.
It's up there.
Up there. Yeah, happens with spinal cord injuries, okay? No, it takes on the temperature of the room, takes on the temperature, yeah. Okay, so for treatment, again, these, like cardiogenic, you don't bolus them with huge amounts of fluids because they're vasodilated, so where's all that fluid going? It's going peripheral, right? It's not gonna stay in our vasculature system. So they need fluids, but again, cautiously. Now, spinal stability. I know y'all covered this last Friday. For these patients, if we suspect a spinal cord injury or a spinal injury, what do you need to make sure that you do? It's like number one priority. Spinal precautions and stability. You've got to get them stable. What does that mean? Sitting up, laying down, turn on the side. Supine, right? Supine. However, if you think neurogenic shock from a epidural or a spinal anesthesia, you raise the bed 30 to 45 degrees. Okay? You raise the bed for those. But for everything else, you're laying flat, you're laying supine. If they have spinal anesthesia or epidural for whatever reason, then you want to elevate the head about 30 to 45 degrees.
So that would be like the cause of.
Yes, that would be the cause, like a pregnant woman who had a epidural and now she's bradycardic, hypotensive, and she's hyperthermic. You would automatically think, oh, this could be neurogenic from her epidural, raise her head. Right, right. Okay, so if I had a patient that came in that said they fell off a roof head first, 10 feet, and now they're having these symptoms, how do you put them? Supine. Do you see any bleeding? Would you see bleeding? Maybe if they had a cut or something, you might see it, or you may not, but could they still be bleeding internally?
Yes.
Absolutely, so you have to monitor for both, okay? Have to monitor for both. How do you know somebody's internally bleeding? Bruising, vital signs, vital signs. What else? If I'm bleeding in my stomach, what happens to my stomach?
Rigid.
Starts getting distended and firm, right? What can happen to my spine? You could have a fluid shift. If I'm laying in the bed and I'm bleeding from my spine, where on my spine would you see bruising? Do you think it's most often?
But
Lumbar sacrum. Lumbar sacrum. You might see it higher up, but most of the time it's gonna be lumbar sacrum. So make sure you check them posteriorly. Maintain their C-spine, their spinal stability, but you still gotta turn them, right? Just because we put them supine, you can't forget about their posterior side. Okay, anaphylactic. We said this is allergic reaction. Give me some examples.
peanuts.
Bee sting, wasp sting, any kind of bug sting, right? What else? Blood transfusions. Peanut butter. Okay, what about a blood product? Yes, don't forget about blood, IgGs, immunoglobulins, stuff like that. What about a new medication? What do y'all think about that? It could happen. It's not real common to go into anaphylactic shock, but it could happen, okay? All right, so look at your clinical manifestations there. Again, we have massive vasodilation, and we need a lot of fluids. We need fluids on these people, okay? Lots of fluids. But look at our manifestations, what's different? Is a lot of them different? Absolutely. Flushing, pruritus, and urticaria. What is pruritus? Itching. What is urticaria?
Hives.
Hives. Times. Raised red splotchy places. Sense of impending doom, chest pain. They can have incontinence, swelling of lips and tongues. So all of this that mimics an allergic reaction, that's just gone into overdrive, right? This can happen within like 2 to 3 minutes, up to a couple hours. So you've got, if they come in and you're thinking anaphylaxis, you've got to kind of ask them what's been going on over the last few hours, okay? Okay, our ABCs, especially with this one, okay? We've got some medicines we added. Now, I'm gonna tell y'all, your book says I am epinephrine. I don't agree with that. But I can't go against the book. I've always given IV, okay? Always given IV. But your book says I am epinephrine, so I'm gonna go with that, okay? Your book mentions they should always keep Benadryl and an EpiPen on them. But for whatever reason, in the treatment, it says I am, but I don't agree with that, but we'll go with it. IV Benadryl, I'm like, why do you give Benadryl IV and not Epi, but whatever. And then the, histamine blockers, your H2 blockers, ranitidine, Pepcid, Protonix, whatever your hospital has. Why do I have nebulized medication? Bronchospasms, because on this slide, I told y'all they're having all of that respiratory issues going on, the wheezing, the striders, the bronchoconstriction. So we need a nebulizer medication. Give me some popular ones y'all know of, that I would probably test y'all on. Albuterol, what else? I'll stick with albuterol. I'll stick with it. Okay. They are severely hypotensive. That's why I told y'all we've got to get fluids on them very quickly, okay? Usually it's the crystalloids. On these, I'm gonna be honest with y'all, they will probably give normal saline more than the LR, but, I won't try to trick y'all, just stick with LR as my first choice. But on these, in real life, normal saline would be their first choice. If hypotension persists after we've given them fluids and after we've given them some colloids, if albumin doesn't work, then they may give them some corticosteroids to kind of help with that larger reaction also. Why do I have prevention of reoccurrence up there? If you know what happened, they need to stay away from it, okay? All right, our last one, septic shock. Sepsis, we said, came from infection, right? So what you need to be looking for is what was their precipitating cause. Was it a pneumonia? Was it a kidney infection? What was going on? What caused them to become septic? That's monitoring for prevention. I've got up here healthcare associated infections. What are these? They got them where? In the hospital. So what is a CAUTI? Catheter associated UTI. How did they get that? Foley, that was what? Not sterile. Was put in not sterilely. Y'all, is it hard sometimes to maintain sterility? If you have a 90-year-old mama who's contracted in every way, is it hard to put it in sterilely? Yes. But we can increase their risk for infection. What's another one? What about those Foleys? They're not cleaned properly. And what else did you say? What do we do with them, y'all? Do nurses love Foleys? You know? I do. I want every one of my patients to have one. Every one of them. Leave them in too long. Leave them in too long. They need to come out. What about IV sites? The new thing now, IVs used to have to be changed every 3 days. A peripheral IV had to be changed every 3 days, regardless. What do y'all see in the hospitals now? As long as it works, right? Some hospitals have gone to 5 days, but even then, they're like, if it's working good, don't take it out, right? So, being that they're in longer, that increases their risk. So what if you have a patient who came in for a UTI, they've had an IV for 7 days, and now we think they're septic? Do we keep using this IV? Pull it out. What do you do with the tip of it?
Check it.
You send it to lab. They need to culture that tip. Same thing if they had a PICC line or a central line. They're going to change that. They're going to switch it over and change it. What do y'all think about, where have y'all seen a central line? Okay, have you seen one femorally? Nobody? You haven't. They don't do them a lot anymore. That used to be where every central line went. You just went the femoral artery, done. But what is down there, y'all? And what's in the groin? Bump. Pee and poo, right? So they won't hardly go in the groin anymore because of it, just its proximity. But wherever they have a central line, they're gonna take it out, you cut off the tip and you send it down. A lot of times you'll send just the whole IV catheter and the lab will cut the culture the tip. Send it down, but you gotta change them out. All right, y'all just did all the ventilator stuff. Tell me about ventilator-associated pneumonia. Give me some stuff you do to prevent it. Hands is always number one, y'all, in everything you do. Closed suctioning, CHG swabs. How often do you do mouth care? I'd say frequently. I don't know exactly what y'all were taught, but it ain't once a day. Okay? Where do you position them? Head flat. Gotta elevate that head of bed, right? What did Miss Lowry tell y'all? 30 to 45 degrees? 30 to 45. Just elevate the head of bed, right? You're not laying them flat. Okay. What about wound infection? If they have an abscess, or they have a burn, or they have whatever, what do you need to do with those wounds? They're real nasty and you can't get them well. What have they got to do? Debride them, right? I heard somebody say debride. They need to go to surgery and have them debrided and cleaned out and get all that nasty stuff off so that they can heal, okay? Okay. What about equipment? What about those Dynamaps? Because this is what I do. I'm guilty. Here goes me and my little Dynamap. We go and bring one, we get this blood pressure off. And I come out, where do I go? Right on in here, and I take her. And I come on down the hall, and I keep going. What should I do with my Dynamap or any of my equipment? Should clean it between each person, right? But who doesn't? Be honest. We have some? Woo! Does. Honey doesn't. You do. You do. I apologize. That's what we should do, but it gets overlooked a lot of times. Okay.
I'll ride along.
Okay. So, there's two things with sepsis I want y'all to be able to differentiate. I highlighted in red the word sepsis. I want you to think of sepsis as the infection. Just overdrive of infection. Whether it came from a UTI, whether it came from a wound, whatever. Sepsis, okay? Just the over blown up infection. So what is new up there to you? Hyperthermia, and what is my skin? Warm and flushed. Where was it warm and dry? Neurogenic. Now it's warm and flushed. Bounding pulses. They're not weak anymore. Look at your urinary output. What is it? It may be normal or or it may be decreased. My blood pressure may be what? Maybe normal, maybe hypotensive. Okay? Now we've got some GI symptoms going on, a little bit more, right? Hyperglycemia, platelets are a little bit decreased, and my WBCs and my CRP are increased, okay? So think of that as your overblown infection. On the next slide, we're going to go into our shock. Things are gonna switch, okay? Now we're gonna be hypotensive, pool model skin. Urinary output is pretty much going to cease or be anuric. We're still gonna be tachycardic and tachypnic, that didn't change. Our temps now may be normal or subnormal. Okay, most of the time it's subnormal. And then we may have multi-organ dysfunction, okay? We're at a risk for MODS. Any questions about those? That's the only way I could help differentiate it. Yes?
On the shock limits ones, are they responsive or not responsive?
In the beginning stage, they may be responsive because their blood pressure may still be normal, but in septic shock, they're not going to be responsive. We're still gonna be giving them fluids, but it's probably not gonna work. Yes? With what? MODS, multi-organ dysfunction, we're gonna talk about it on the slide. We're gonna talk about it more in depth, a little bit. Okay, here's our treatment, okay? Again, it's aggressive fluids, it's our vasopressors, our oxygen, but we're gonna add antibiotics. What do you need before you start an antibiotic? Cultures. Where are you gonna get cultures? Everywhere. Those tips, sputum, urine, whatever, blood, you're gonna get cultures. Then you start your antibiotics. You want your antibiotics started within an hour of being diagnosed or suspected of septic shock. Do you think that happens? If you gotta get a culture from everywhere, it may take a little bit, but that's your goal, is to try to give it within an hour. We've still gotta maintain those glucose levels, we're still doing DBT. We can still give those corticosteroids if we need to, just like with anaphylactic shock. Okay? That's the best I could do to help y'all differentiate the different types. I didn't know how to do it. But what I can say is, you just have to know your stages, and you have to know all of your shocks. How would I tell what kind of shock they're in? How would I treat it? What would I see? And I may be asking you about a stage, or I may be asking you about a type. Okay, I will try not, my best, if I do, I don't mean to. I will try not to give y'all, I'm asking y'all, they're in the cardiogenic shock, but they're also in the compensatory or progressive. I'm not gonna try to trick y'all like that, okay? I will be asking y'all about one or the other, okay? All right, it's 10 o'clock, let's go to 10:10. Hyperperfusion, we have hypermetabolism, and we have activation or overproduction of the inflammatory system, right? With sepsis, that's always gonna come from infection. With SIRS, what I want y'all to know is it can come from sepsis or infection, it can come from infection, or it can come from things like multi-system trauma. It can come from ischemia or infarctions like an MI or a stroke. So the inflammatory response can come from other things other than infection. With sepsis, it's always infection. With SIRS, it's infection or something else, okay? But they kind of mimic each other, okay? It's just the cause is different. What happens is, everything is systemic. If my trauma was in my pelvis, I had a crush injury to my pelvis, I may have inflammation in organs like that are distal or proximal that are away from my pelvis. With sepsis, my infection is gonna start in my urinary tract system and then go systemic, but with SIRS, it starts in one part, your infection does or your trauma does, but your inflammatory response starts in another place. Does that make sense? Infection, it starts somewhere, say it's my lungs, and then my inflammation spreads systemically. With with SIRS, your inflammation starts elsewhere other than the area of infection or trauma. Okay? Okay, the criteria is very specific, so you're just gonna have to memorize it, okay? The temp is either less than 96.8 or greater than 101. If it's in between there, your book says it's not clinically classified as SIRS. So you're just gonna, like I said, you're just gonna have to know them. Look at your WBCs, it's very specific about the parameters for your WBCs. Questions about that? I've hardly ever seen anybody diagnosed with SIRS, it's usually just sepsis is what they call it. Okay. Multiple organ dysfunction syndrome, MODS. MODS is going to come from either SIRS or from sepsis, okay? It's when 2 or more organs have ceased to function independently. They are gonna require medications or some kind of mechanical ventilation or one of those heart pumps to maintain their status. So 2 or more organs. It's usually gonna start in the lungs, so what you're gonna see first is respiratory issues, and then it's going to spread, but usually in the lungs. What is autocatabolism? What's that mean? Breaking down of like smooth muscle, skeletal muscle. The body's gonna start saying, I can't get my energy from carbohydrates, so I'm gonna get it from protein, I'm gonna get it from fats. I'm still in that anaerobic metabolism, not my aerobic. So I'm still gonna be acidotic. I'm still gonna have problems with my inflammatory response, therefore my coagulation cascade. Everything is just getting worse, okay? High mortality rate. If 2 or 3 of your organs are not functioning, do you think there's a high probability of death?
Right.
It's kind of like the irreversible stage. You almost think of it that way, okay? And again, everything up there is the same except for promoting communication. So go back to that irreversible stage. Who are we taking care of the most? The family. So communication is going to become very prominent in this stage with MODS also. Okay, we've got to talk to the family because with a mortality rate of 75%, most of these patients are going to die. Okay, so it's comfort measures and communication. Okay, this is not going to change much, so we're going to hit it very quick, okay? Respiratory system, they have to be on a vent, okay? They're going to be on a vent because all of the respiratory system is basically shut down. Our cardiovascular system, they're going to be getting the vasopressors, lots of fluids, and they're probably going to have some kind of mechanical assist device because again, that pump is shutting down. In this stage, the albumin is not going to work, okay? They'll give them blood products that will work better, but those colloids are not gonna have much effect in this stage. For our renal system, we're gonna be anuric. There is no less than 30 is not good. They have 0 urine output at this point. For our GI system, the gut has pretty much shut down. They're probably not going to be on tube feedings at this point. They're going to be on TPN or parenteral. Depending on their GI system, they can still be there, but probably we're going to be at TPN at this point. Am I going too fast? Y'all okay? Okay, hypermetabolic state, again, all of your enzymes are going up higher, you're more jaundiced. We have 0 immune function, so we're at even more risk for even more infections. Where do you put these type of people? They're almost immunosuppressed is how you have to think about them, okay? So they're typically not in isolation, but we need to really limit visitors, really limit people coming in, okay? Really kind of watch these people. Look at insulin resistance and hyperglycemia. What kind of medicine are they gonna be on for that? Sub-Q insulin by sliding scale? What do y'all think? Insulin infusion by pump? Q1 hour Accuchecks? Yep, they're gonna be on an insulin infusion because they're not making any insulin at this point. Neurological symptoms, they're gonna be pretty much comatose, y'all. Pretty much comatose, okay? Okay, prognosis is poor. So again, I told y'all, prevention and early signs is what we want to do as nurses to prevent them from getting to MODS, okay? And it starts way back at the beginning of the lecture with prevention of all those different types and the different stages, okay? DIC. This is in chapter 29. There's a section in there, I think it's a page or two, there's not much in there on this, but it's in chapter 29, but don't read the whole chapter, just pick out the DIC part, okay? Because this is a big chapter. Okay, DIC in basic terms is we have excessive clotting and or excessive bleeding at the same time. What occurs most commonly is excessive bleeding from thrombi, okay? That's what you're gonna see the most with DIC. Occasionally, you will have a patient that has excessive bleeding. And we'll talk about that then, okay? So with circulating thrombi getting stuck everywhere and anywhere in your circulatory system, what do you think you're going to see clinically? What do you see? Okay, it's in the brain. What do you see? Stroke, altered level of consciousness, y'all know this. What is in the lungs? All those symptoms of PE, right? Respiratory distress. What if it's in a leg? Ischemia, DVTs, cold extremities, decreased capillary refill. Okay, y'all know this stuff. What is in the kidneys? What do you see? Decrease, increase, okay. BUN and creatinine, yes. Decreased urine output, okay. What about, if it is in the, what if it's, bleeding, what are we gonna see? Excessive bleeding. Bruising. Petechiae, those little spots I showed y'all. That's some of the first stuff you see. What else? Where else can you see blood? Urine, what's that called? Hematuria. Where else can you see it? Stool, what's that called? Occult blood, hemoccult blood. Thrown up in the vomit. Where? Everywhere, right? Ears, eyes, NG tubes, out of the Foley. What about IV sites? They'll bleed around those sites. If they have big central lines, sometimes it'll start backing up and oozing from the site. If you've never seen it, it is pretty cool to see. Your patient's not doing good, but it's really cool to see as a nurse. Usually at the big, if it's in the early signs, it's gonna be bright red. If it's dark or coffee ground, that's an old bleed, right? So they've been bleeding for a while. There is acute DIC and chronic DIC. I think it's on the next page. There's y'all another chart, y'all don't do no chart. Okay, so common causes of DIC. Look at those obstetric complications. Y'all talked about all of those, fetal death syndrome. Your intravascular hemolysis, that's whenever you're getting blood, you can have a reaction. Heat stroke, head injuries. Okay? So you need to know those, need to know some common causes of it. Sometimes the cause is just not known. You can have acute and chronic. With acute, when do you think you're gonna see that? Give me some examples. Sepsis, postpartum bleeds, abruptio placentas, trauma, those are gonna be your acutes. Your chronics are gonna be like your cancers, your chronic illnesses, those things, okay? But they can be both. Over here on this side, y'all told me some of those. Think about the mouth. We don't look at the mouth a whole lot, especially if they've got an ET tube, but sometimes they'll bleed from their gums. So I'll tell y'all what happened to me. I had a patient in the CCU. I don't know what she was there for. Never forgot that, but she was on a vent. She had an NG tube, Foley. She had a tube everywhere. She had a central line. She had a pH1 scan cap, arterial line. And she also had C. diff on top of it. So we were actually cleaning her up, is what we were doing from a bowel movement. And didn't see anything in her stool, it just had that look and smell of C. diff. But whenever we turned her back down, she had a trickle of blood from her ear. Well, I thought we had hurt her ear because, you know, we've been rolling her. So I'm looking at her ear and it's just a little trickle and I'm like, I can't really see it. I guess it's coming from inside. And as I'm trying to find an otoscope to look down, she starts bleeding from a little trickle down the tube with the NG, the snare with the NG tube in it, just a trickle. And it's just not occurring to me yet what's going on. And I'm like, what in the world? And within a matter of minutes, like she had had another massive explosion of diarrhea that ran off the bed that had bright red in it. Her NG tube, her container filled with blood. Her IV site, she was oozing from everywhere, and she died within a couple of hours. So it's really amazing to see, as a nurse, to see it come to life, like from every orifice. But anyway, she died, so it's not a good thing, but it's cool to see. Yeah, cool to see, but it's not very common because they most often, like I said, have the thrombi versus the bleeding. Can they have both together? Absolutely. Okay. So for your lab, your platelets and your fibrinogen are going to be decreased, but everything else is going to be increased, okay? What is D-dimer indicative of? Clots. Greater than 250. Greater than 250 is kind of your normal. Okay, so for management and treatment, what do we want to do, y'all? We've already said it 500 times. Prevention and controlling it, right? Controlling that bleed if we can. Everything they need, we've already treated in shock. There is one difference. Heparin. Heparin is given for what? IV heparin or sub-Q heparin is given for what? For clots. So do these patients need heparin? Yes and no, you're exactly right. If the benefits of them getting it due to the clots is greater than the risk of them bleeding, they're gonna put them on a heparin infusion. If they're not bleeding at all, they may try enoxaparin or some kind of low molecular weight heparin. But heparin is one of the standards for treatment in DIC, okay? But of course, if they're actively bleeding from every orifice, we're not giving them heparin, okay? But they will get heparin. Okay. A couple of other things about DIC. Avoid trauma and invasive procedures. What are invasive procedures that we do all the time, every day?
Blood pressure.
Labs drawn every day or multiple times a day. How many times do we stick them sometimes trying to get an IV?
Two or three.
2 or 3. They need a central line or some kind of line where they can avoid all those sticks. They need a central line. But if you do have to stick them, what do you have to do? Hold pressure a lot longer than we're normal used to. Your book says 5 minutes or more of continuous pressure. What if they need an IM injection? We need a different route. We need to call pharmacy, right? They can get us a different route. What about rectal meds, rectal Tims? That's a no-no, okay? With intracranial pressure, they can bleed in their brain, right? So we need to control that. What are ways to control intracranial pressure? Positioning of where? Where you want to put their head of bed? 30 to 45 degrees. Do they need a lot of stimulus? No. You need to control their pain, control their temperature. Keep them calm, quiet, and everything as normal as you can get it vital sign wise. Okay. That's a lot.